Today, we're diving into a medical condition that's often described as a living nightmare, and yet it's so frequently misunderstood and even dismissed. We're talking about akathisia, and trust me, it's so much more than just feeling a little restless.
Just listen to this firsthand account from Phil Nolan. Involuntary muscle contractions, waves of anxiety. This isn't just fidgeting, not even close. This is a raw internal torment. And to understand akathisia, we have to start right here with this experience.
So you have to wonder, what exactly is this condition that can cause such deep suffering? And maybe even more importantly, why is it so often ignored or worse, told it's all in your head?
To answer that, we really need to get to the heart of what akathisia is. We've got to move beyond these simple and frankly incorrect labels like anxiety or agitation.
So at its core, akathisia is a neuropsychiatric syndrome. And the name itself is a huge clue. It comes from the Greek for inability to sit. And wow, does that capture it perfectly? It's this intense inner restlessness paired with a powerful, uncontrollable urge to always be in motion.
And this, right here, is where so much of the confusion comes from. People mix it up with anxiety all the time. But look, akathisia is a movement disorder. The need to move is a physical compulsion. Anxiety, on the other hand, is a mental health condition where restlessness is often born from fear or worry. The absolute tragedy here is that the sheer distress of akathisia can cause anxiety, creating this vicious feedback loop that leads to misdiagnosis.
And it's not a one-size-fits-all condition. Clinicians actually break it down based on when it shows up and how long it sticks around. You've got acute, which pops up pretty quickly after a medication change. Chronic, if it lasts for more than 6 months. There's also tardive, which is sneakier with a delayed onset. And you can even get withdrawal akathisia when you stop or lower a dose.
So, where does this thing even come from? Well, the answer, in the vast majority of cases, points in one direction: medication.
The science really points to a major disruption in our brain's chemistry. The main theory is that certain drugs basically act like a roadblock for dopamine. Now, you can think of dopamine as the brain's air traffic controller for movement. So when its receptors get blocked, the whole system is thrown into chaos. That's what creates these uncontrollable urges to move.
And listen, we're not talking about some rare, obscure drugs here. The list of medications that can cause this is surprisingly long and full of common ones. Of course, there are antipsychotics, but we're also talking about widely used antidepressants, common anti-nausea drugs, and even certain blood pressure meds and antibiotics.
So, just how big is this risk? Well, let's put some numbers to it, because the data from clinical trials is pretty stark. You see, about 3.7% of people taking a placebo might report these kinds of symptoms. But that number can shoot all the way up to 13% for people taking certain newer antipsychotics. The risk is absolutely real, and it's measurable.
Okay, so given this clear risk, how is the medical system supposed to see the signs and respond? This is where good diagnosis and solid policy are meant to work together.
To try and get a handle on this, clinicians actually have objective tools, like the Barnes Akathisia Rating Scale, or BARS. It's basically a standardized checklist that's designed to turn a patient's horrible subjective feeling into a score that can be tracked.
So how does it actually work? Well, it's pretty smart, really. It has a few different parts. First, the clinician just observes the patient's movements. That's the objective part. Then the patient gets to rate their own inner restlessness. They also rate how much distress it's causing them. And finally, the clinician gives an overall assessment. It's meant to be a full picture. But here's the heartbreaking reality. Even with tools like BARS, the experience for patients can be the complete opposite. Phil Nolan's story just highlights this devastating gap. He had the clear symptoms, but he was told over and over that it wasn't the drug, it was him, that it was all psychological. It's a textbook example of the kind of medical gaslighting so many people with akathisia face. And this is the very thing that official policies are supposed to stop from happening. I mean, look, the New York State Office of Mental Health has a whole detailed manual specifically on how to manage medication-induced movement disorders just like akathisia.
And their plan, when you look at it, is just so logical and straightforward. Step 1, be careful when prescribing. Use the lowest effective dose. Step 2, monitor patients regularly to catch any early signs. Step 3, have a treatment plan ready to go. Step 4, and this is crucial, educate patients and their families about the risks. And finally, keep reviewing cases to get better. The framework is there.
So what happens if this condition does pop up? What can be done? Are people just stuck with it? Absolutely not. Fortunately, there are clear paths to treatment and real hope for relief.
The first and most obvious step is to go right to the source. Whenever it's medically safe, the doctor can either lower the dose of the medication that's causing the problem or switch to a different one entirely.
Now, if changing the main medication isn't an option or isn't enough, there are a bunch of other tools in the toolkit. Propranolol, a beta blocker, is often the first thing doctors try. But there are other options like mirtazapine, vitamin B6, and benzodiazepines. And there's some really fascinating new evidence around iron. Seriously, for some patients who are iron deficient, just getting their iron levels back to normal has made their symptoms completely disappear.
And get this, the science is moving fast here. A brand new meta-analysis from 2024 actually found that both mirtazapine and vitamin B6 might be even more effective than propranolol, which has been the standard for years. That's a huge finding that could really change how doctors treat this. And make no mistake, we need these new treatments. Because the scale of this problem, it's huge. In some groups, like people with schizophrenia who are on certain medications, the rate of chronic akathisia is as high as 1 in 4. 1 in 4. This is not some fringe side effect. It's a major clinical problem. So it all brings us back to this one critical question. We know the signs of akathisia can be seen. We know the patient's suffering is real. We have the tools to measure it and policies to manage it. So if the signs are there to be seen, whose responsibility is it to actually listen?